So we're going to talk about ways to get the medicine into the body, ways that the body distributes it, what factors into those things. Like, we can take a medicine, we don't absorb it the same at the same rate each way we take it, right? Like, as for example, when you get IV drugs and anesthesia, they hit you a lot quicker than if you take a pill at home, correct?
Yeah.
If it's a pill that causes that kind of effect. Well, why is that? And then adverse reactions and a few other things here. So there's four main ways drugs act on the body. Okay, and when you take a drug, your body's going to break that apart into certain molecules, and then those molecules can then go to the site where they are active. Because remember, I don't think we really covered enzymes, but it's like the lock and key mechanism. Every cell has a receptor on it to where only a certain thing can fit in it. It's like the lock and key. So this medicine has a certain receptor site on each cell that only that cell it can fit into. And that has to be broken up to where it can be into this form and hit that cell and activate with it. And when it does that, there's four main ways it affects you. One's depressing, like a CNS depressant. Okay, so like pain pills depress our pain perception, or stimulant. It can destroy cells, so not only just human cells, but bacterial cells, something that's a pathogen, right? They're cells too, and we have to kill them sometimes because they cause infection in us. And replace substances. So can you give me an example of that? Like, what's one thing I talked about we had to take sometimes when we get low on it? Causes seizures.
I know one of the medicines I'm taking, I'm low on vitamin C.
Okay, that's a great example. May not be getting enough, so you gotta replace it. I was thinking of sodium. It could be cancer cells as well, destroying cells. Sometimes they need to be killed, right? Like chemotherapy. Okay, drugs can also slow up or speed down normal things that are happening. So, for example, my allergies might be in overdrive, and I'm itchy eyes, watering, runny nose. I take a Benadryl. That's still happening, but it's slowed down dramatically because that Benadryl has told those cells to slow it down. Just like I said, some drugs will kill cells. And then we talked about replacement. They give example of potassium and calcium carbonate. So once it's in your body, there's four things that medicine usually does. You got to absorb it. It's got to be distributed to the certain target tissues. It does its work, and then you excrete it when you don't need it, right? Energy cannot be created or destroyed. It can only be rearranged. And that goes to the atoms and the molecules that are in these medicines. Okay, so absorption means that medicine has entered your bloodstream. And here in a minute, we're going to talk about all the ways medicine can enter a bloodstream. But this is where it really comes down to how quickly you absorb it, because there's a bunch of different ways into your bloodstream. Can you name a couple? One's IV. How does it get into your bloodstream after you take a medicine and swallow it? What happens?
It dissolves.
And goes into what organ? What's after your stomach? Your intestines, right? The lower intestines. And that's where food is broken down and nutrients are absorbed out of it, right? And it crosses across that intestinal wall into the bloodstream. A lot faster, or a lot slower than IV, a lot slower than inhalation. Okay, so we give a route depending on how we want them to absorb it. And so here are the routes. Sublingual. I'd say it's pretty fast, right?
It goes under the tongue, and that's one of the
Mucous membrane. And there's blood vessels right underneath that. It's like nitroglycerin. We want that to take effect quickly. We give them a dissolving tablet. Orally. And it's probably medium to slow. It can be affected by food in our stomach, things like that. Sub-Q. That's an injection, right?
Yeah.
And IM. And then IV. And so we know IV is fast. Well, which one's faster between these two, would you imagine? So I want you to think about the two layers of skin. We had the epidermis and the dermis, right? What was down here? Blood supply, all the blood vessels. And if we're given a subcutaneous underneath one of these layers here, that medicine has to be absorbed before it can finally enter the bloodstream. So it's usually slower acting. This is things like insulin we give sub-Q, where it's absorbed gradually by diffusion and things like that, and the cell's taking it up, and then enters our bloodstream. But IM, we're going below all this into the muscle, and the muscle's got lots of blood flow around it. It's really vascular because we're always doing work, and they need a lot of energy and nutrients taken to them and things like that. So IM is a lot faster. It's going in. It doesn't take very long to get the blood supply at all there. And that's why it tells you, you know, under the skin and the muscle. We just went a little bit further and talked about that, what's really going on there. Not mentioned up here is inhalation, which is even faster than IV, I think. And then I think...
I wonder why. IV's going right into the...
Right, I mean, but after a second of pushing it, sometimes you can feel the effects. But I think because your lungs have such a large surface area and there's so much blood that's getting contacted at once there, it's faster. A dose is put in faster to your blood. And I think even faster than that is rectal. Like if you give a suppository, it's even faster because that medicine melts and there's a lot of vessels there and stuff like that, a lot of nerves. I have to go look it up. Distribution. Okay, that's kind of what we talked about here. As it's being distributed or going into the vessels, once it gets in there, it either goes to the brain or it goes to the lungs, wherever that target tissue is. If it's a bladder drug, it's going to go to those muscle or those cells targeting in the bladder, like for bladder spasms. It'll target those cells in the bladder wall. We are mainly water, so most of the medicine we take needs to be water soluble. Okay, and then the biggest worker of metabolism is our liver. But we got other things like kidneys, lungs. Then we excrete it. It can be excreted either in your urine, your feces. You can breathe it off. You can sweat it out. Why is it a problem for the elderly with kidney problems? Like if they're getting vancomycin, we constantly have to pull renal values in labs to see like if their creatinine's gotten too high or not, because we're checking their kidney function constantly as they receive this vancomycin. It can become toxic real quick because it's excreted mainly by the kidneys. So like Advil versus Tylenol. You take too much Tylenol, that's going to hurt your liver and not so much your kidneys, because the liver is where that's metabolized at. Tylenol is very toxic to the liver. But on the other hand, Advil, which is an NSAID, is metabolized and excreted by the kidneys. Well, it's excreted in the kidneys and it can build up and hurt your kidneys first. So
either way, you're up the creek.
Yeah, if you take too much. Okay, you want to make sure, I mean, you should be asking women if they're pregnant when you're giving them new medicines. They should be aware of that if they're in that age and it's a possibility. And a lot of times it comes down to risk towards the fetus versus benefit of the mom. Like if mom has a wisdom tooth pulled, we wouldn't want them to take any pain medicine, no Motrin, period. Motrin's bad for pregnant women, but no Lortab or anything like that until after the first trimester, because during the first trimester they're developing. Cells are being formed, and those chemicals coming in from that medicine can mess up that development. But after the baby's already formed and it's just growing, it's not so much a risk. So we would say either if you can wait, come back until you're in the second or third trimester. First of all, just so we're not messing with the development of a fetus. Second of all, whatever medicine they got to take, the baby's just going to be getting a little bit of it, but it's not going to be messing up development. And then say the baby's born, they got to get a tooth out or some kind of surgery. Well, they might have to take the pain medicine. They might want to take it as little as possible, but they're still going to have to take it. That benefit for the mom is going to outweigh the risk of the baby getting a little bit in the milk. And usually it's not a problem. I mean, the human body is built to metabolize and excrete stuff, so. A lot of times they don't know if it's even in the breast milk or if it has a problem, but it depends. Does the mom really need this medicine? So age has a big difference. Babies obviously metabolize things faster, and that drug will work quicker on them than it will an elderly person. And all those drugs you're looking up in your book right now, like for Tylenol, the adult dose is so-and-so, it's based on a person in this age range in these pounds. So sometimes that's why we're worrying about kids and elderly calculating things by weight. Sometimes we got to do that. Diet can make a huge difference in medicines you take. For instance, Coumadin. If you're taking Coumadin, it's thinning your blood. And so in leafy green vegetables, there's a high amount of vitamin K. And patients who are taking Coumadin therapy, we tell them no leafy green vegetables because that vitamin K will interact with that Coumadin and cause even more bleeding. And there's some of these are pretty famous. You'll get to know them real quickly. Some of them are a little bit more obscure, but you don't drink milk with tetracycline. I don't know that one exactly why. I do know things like you'll read like on the label for Xanax it says don't drink pineapple juice or some other juice with this because it causes the drug not to be metabolized as quickly and it stays in your system longer. And women and men are different in the way they metabolize things, and it makes a huge difference. Like a study came out after 12 years for Ambien. They realized that women who've been taking Ambien for like 10 years, their liver was way more wrecked than men's, and they've been dosing them based on one weight and one sex. So they had to make separate doses for women and recommend it. Yeah, that does happen too. Heart disease, kidney failure, diabetes, and low blood pressure can affect drug action. Psychological factors, yeah, the placebo effect, you heard of that?
Heard of it, but
So placebo is simply a sugar pill, doesn't have any effect on you. And in clinical trials, like a blind study, well, it's not a blind study, that means the doctor doesn't know what they're giving, but they'll have a patient, they'll give them a pill, and they don't know if it's the drug or the placebo that they're taking, and they'll monitor their effects and measure it. And so if the patient says, oh, I feel better, and then all they got was placebo, then we know the drug, we can compare that to whatever the drug actually did and see if there was any real effect on it. And it does make a huge difference. People who are really nervous when we're putting down in the chair to go to sleep for anesthesia, or people who they were just worked up, they're usually harder to anesthetize and keep under because they're so worked up. Adrenaline's pumping, things are metabolizing quicker. I'm pretty sure I had one patient I'll never forget. We knew her father was an alcoholic. She kind of knew the people in the practice a little bit. Long-term alcoholic, and I knew she had some drinking problems. So there's something hereditary there. And when we put her to sleep, it's like we wouldn't even put drugs in her. She fought us the whole time, couldn't even keep her to sleep. And I'm wondering if there's something along that lines that was causing her to metabolize those drugs faster. We all know that, right? Okay, time of administration, that's important too. Sometimes we tell them to take it early in the morning, like cholesterol medicine is in the morning before meals. Usually other drugs you need to take at night at bedtime. Depending if it's unwanted side effects, like if it's going to make you pee a lot, you want to take it in the morning and not at night for bedtime issues, things like that. Always check allergies, never assume. You know what happens when you assume. And that is true, but it's probably negligible. Okay, so I would take note of these. There's a therapeutic effect and a side effect. Therapeutic effect is what you want. What is the therapeutic effect of Motrin? It is decreased swelling, inflammation, and decreased pain because of that decrease in swelling, inflammation. Some drugs have unintended side effects. Some are good, some are bad. For example, a lot of times in the nursing home, I get a couple patients that don't have a good appetite. We'll give them an antidepressant because a side effect of antidepressants is increased appetite. You eat more, you gain weight. And we prescribe it for that side effect, basically. For a young person, taking an antidepressant, it's a bad side effect because they're going to gain weight, right? Morphine, the therapeutic effect of that is obviously painkiller, but a bad side effect is it depresses your respiratory drive, causes constipation, because your bowels slow down, they're not as motile. You stop making urine. I would take note of these two, local and systemic. There's two ways a drug can affect you. For example, Benadryl ointment, you put it on your skin, it's only affecting that local area. But other drugs you take might have a systemic effect. They go through your whole system, your systemic circuit, right, in the blood. And this is the same example or two different examples for the same drug here. Local Benadryl on the skin relieves that itching or problems there, and then if you take it by pill, it's going to act throughout your whole body on the histamine agonist. I wouldn't worry too much about these right now. You can go back and review these later. This slide, I'm not going to read, just read it to you, but so adverse reactions. A good example of antagonism, I would write that one down, is birth control. You're taking birth control, you get prescribed antibiotics, guess what? Your birth control don't work as good anymore. It causes one drug that you're taking to have a weaker effect because of the drug you're taking now. Interaction, therapeutic, adverse effect on the body, physical dependence, we know about that, and psychological dependence. So the difference between these two is you can have a person that's been taking painkillers for 10 years and they won't have a physical dependence on it. They will have a physical dependence on it to function, but they won't have a psychological. They don't need that drug. They don't treat something psychological with that drug. It's like, oh, I'm having a bad day and I just want to take another pain pill. They take them one time, they say, oh, my back is hurting, or if I don't take this, my back will hurt, and I'm going to take it as scheduled, and they don't think twice about it. It can be a real great area, and I'm not here to judge anybody, I'm just saying, people can be on drugs for a long time and not develop a psychological dependence on them. I've seen it. Some people are on chronic medicine, but a lot of times they don't. I just watched a video the other day of them. The pharmacy that made OxyContin interviewed patients and then interviewed them again 10 years later. And when they were starting out, they were all like, oh, this drug has changed my life. I can do this, I can do that. And then 10 years later, I think 2 of them are dead. One of them they couldn't find, and the fourth one, they were like, I barely made it out alive. But Oxycontin's a whole different bear. So, anyways.